This is Stephanie Huff, and I'm recording another concept on perfusion. This one is going to be on strokes. So strokes can be called brain attacks, they can be called CVAs, cerebral vascular accidents, but basically these are all a condition in which neurologic deficits result from a sudden decrease in blood flow to a localized area of the brain. They can be ischemic or hemorrhagic. Ischemic strokes is when blood supply to a portion of the brain is suddenly decreased by a thrombus, which would be a blood clot, an embolus, which would be a foreign matter, or stenosis, which would be narrowing. In your hemorrhagic strokes, this is when a blood vessel breaks open, spilling the blood into the spaces surrounding the neurons in the brain. Your neurologic deficits can vary depending on the area that it's affected. Strokes are the fourth leading cause of death in North America. Survivors usually have some degree of impairment, and there's a highest incidence in individuals greater than 65. Looking at your pathophysiology, so blood flow and oxygenation are decreased to the cerebral neurons. The cellular metabolism will cease as glucose, glycogen, and your adenosine triphosphate levels are all depleted. The cells will start to swell as sodium draws water into the cell. The cerebral blood vessel walls also swell, which further decreases blood flow. Even if the circulation is restored, vasospasms and increased blood viscosity can continue to impede blood flow to those areas of the brain. Your dead or dying cells are surrounded by a penumbra, which is basically a band of minimally perfused cells. The neurologic deficits are used to identify the location in the brain that the stroke has occurred. Your contralateral deficits, these are symptoms that occur on the opposite side. So basically a stroke that occurs in the right hemisphere of the brain are manifested by deficits on the left side of the body and vice versa. Alright, and so this is just kind of showing you some pictures that show where the stroke has occurred. And so some of these are CTs, some of them are MRIs, and so you can see basically where these white areas are is the areas of stroke. So your ischemic strokes, these result from a blockage and or stenosis of a cerebral artery, which reduces or stops the blood flow and causes a brain infarction. Your transient ischemic attacks, are your TIAs, sometimes are called mini strokes. They are brief periods of localized cerebral ischemia that causes neurological deficits that last less than 24 hours. They usually last less than an hour or two, but the key thing with your TIAs is that they last less than 24 hours. Warning signs of an ischemic thrombotic stroke are these TIAs, and so they may have several TIAs before they actually have a massive stroke. Some people only have one TIA before they have a stroke, but these are basically things telling you to get whatever fixed so that they don't have a massive stroke. And so usually with TIAs they have these deficits that last, like I said, less than 24 hours, and then they have a full recovery, but it is a warning sign that a stroke is ahead. Your thrombotic strokes are caused by occlusions of large vessels by a thrombus. They tend to occur in large arteries that bifurcate, and so that's where they kind of split off. They have narrowed lumens from atherosclerotic plaques. Most common area for a thrombi is your carotid artery, vertebral artery, and the junction of the vertebral and basilar arteries. Your thrombotic CVA occurs rapidly but progresses slowly. It often begins with a TIA that continues to worsen over 1 to 2 days. Your embolytic strokes are caused when blood clots or matter through the cerebral vessels becomes wedged in these really small vessels and permits further movement, so it can't go any further. So your embolytic strokes, these are areas of the brain that becomes blocked because of ischemic changes. It's usually seen in patients younger than those with thrombotic CVAs. It could be from blocked carotids, could be from AFib, a recent MI. Usually has a sudden onset and immediate deficits. If the embolism is reabsorbed by the body, the symptoms will disappear in a few hours to days. If not, then the symptoms will persist. When you're looking at your hemorrhagic stroke, this occurs most often in patients that have sustained elevation in their systolic and diastolic blood pressure, or it could be from an intracranial hemorrhage, and this will occur when a ruptured cerebral blood vessel occurs. And so that causes your intracerebral hemorrhage or intracranial hemorrhage, results from bleeding into the brain tissue. An aneurysm is basically a bulging, weakened area in the wall of the artery, and it can actually rupture, causing a hemorrhagic stroke. This form of CVA is the most fatal. A lot of times when people have massive strokes and they die from it, this is the kind of stroke that they've had. There are two types. There is an intracerebral and a subarachnoid. Like I said, your intracerebral has bleeding into the brain tissue itself. And I've got you some pictures of your hemorrhagic stroke and then bleeding within the brain tissue. And so this bleeding in the brain causes compression of adjacent tissue, can cause blood vessel spasms and cerebral edema. Your subarachnoid type is bleeding into the spaces around the brain, and the blood will enter into the brain tissue, causing damage. So your hemorrhagic CVAs, these occur suddenly, usually during activity. Hypertension is going to be your most common cause, but it can also be from a rupture of a brittle artery wall, a ruptured aneurysm, could be from trauma or tumors. There are AV malformations, which is an arterial venous malformation, and that's basically what you see over here on this top picture, and that will actually cause, they have lots of feeder arteries and these draining veins, and they all get very, and there's just a big clump of them, and they get very dilated, and so they're at risk for breaking and rupturing. Hemorrhagic strokes are linked with poor outcomes. Your manifestations are going to be very rapid. Pressure on the brain from increased intracranial pressure can cause coma and death. And so this is showing you the aneurysm that has ruptured and is causing them to have a stroke. This, you can see lots of blood around the brain from a stroke. There's your subarachnoid hemorrhage, and then this is a CT showing you the bleeding area in the brain. So sometimes with your patients, they will have warning signs before they have a hemorrhagic stroke, and so they may have headaches, and when they come in and say, this is the worst headache of my life, you need to take them seriously. And make sure that you follow up and assess that, because they were at risk for hemorrhagic stroke. But you also have to be realistic in that a lot of patients think that their pain is always the worst. So if they're laughing and talking on their cell phone or texting people and they're saying it's the worst headache of your life, it may not be truly their worst headache of their life, but you still want to make sure you follow up on it. Alright, and so these are just showing you the difference in your thrombotic, embolytic, and your hemorrhagic strokes. Alright, risk factors. Hypertension is going to be the leading cause. Heart disease, especially AFib, will increase their risk. Heart failure, heart valve disease, dilated cardiomyopathy. Patients with diabetes mellitus are often overweight, have high blood pressure, and increased cholesterol, all of which are risk factors for developing a stroke. Sleep apnea, a lot of times that causes them to have hypertension and causes decreased oxygen and increased carbon dioxide in the blood. Your increased blood cholesterol levels increases the risk for atherosclerosis. Smoking doubles the chances of a CVA risk, and that would be ischemia and cerebral hemorrhage. Smoking plus the use of oral contraceptives also really increases the risk. Your sickle cell disease is due to changes in the red blood cell shape and the increased blood viscosity, and so they have a tendency to clump together, and that can cause an embolus. Your substance abuse, typically your marijuana, anabolic steroids, heroin use, cocaine use, and amphetamine use are all increased risk factors. Living in the stroke belt, so that's the southeast United States, so basically where we are. Family history of strokes, obesity, a sedentary lifestyle, recent infections that could be viral or bacterial, history of TIAs, and the use of oral contraceptives. Alright, pregnancy, childbirth, menopause, migraines with aura, autoimmune disorders like diabetes and lupus, clotting disorders, and a previous stroke are also risk factors. Your clinical manifestations are going to vary according to the cerebral artery involved and the area of the brain affected. So manifestations are always sudden in onset, focal, and often one-sided. So your common manifestations are going to be weakness of the face, arm, and leg, numbness on one side, loss of vision, speech difficulties, sudden severe headache, and difficulty balancing. So this is showing you manifestations of right and left brain strokes, and so it shows you your contralateral symptoms, and so you can kind of see on here for your right brain damage, so that's a stroke on the right side. They have hemiplegia, which is paralyzed left side. So a lot of times they have a neglect of that left side. They usually tend to deny or minimize problems. They have rapid performance and short attention span. They usually are impulsive and have problems with safety. They have an impaired judgment and impaired time concept. So in your left brain damage or left stroke, they have hemiplegia on the right side. They have impaired speech and language, aphasias. They have impaired right and left discrimination. Usually have slow performance, and they're usually more cautious. They are aware of the deficits and will develop depression and anxiety as a result. And they will also have impaired comprehension related to language and math. So complications, looking at your sensory perceptual deficits. Your hemaniopia is loss of the half of visual field of one or both eyes, and so that is a picture showing you what their vision would look like. Your agnosia is the inability to recognize one or more subjects that were previously familiar. This can be visual, tactile, or auditory. Apraxia is the inability to carry out some motor pattern, like drawing a picture, getting dressed, even when the strength and coordination are adequate. Neglect syndrome, it's also called unilateral neglect, is basically they ignore the part of the body that doesn't work, and so they just pretend like it's not even there. Not as common is pain, but that does include hot and cold sensations, and that causes lots of pain. It's usually described as a burning, tingling, sharp, stabbing pain, and it's not usually relieved with pain medications. Alright, your cognitive and behavioral changes. They have changes in consciousness, which can be from mild confusion to coma. Emotional lability, so they may laugh or cry inappropriately. Loss of self-control is manifested by behavior like swearing or refusing to wear clothing, and so it's all just kind of bizarre kind of behavior, which is not normal for them. Decreased tolerance for stress. This results in anger or depression. Your intellectual changes, they may have memory loss, decreased attention span, poor judgment, inability to think abstractly. Looking at communication disorders, the result of the stroke affecting the dominant hemisphere. Aphasia is inability to use or understand language. And so there are several types of aphasia. The first one is expressive aphasia, which is a motor speech problem, which one can understand what is being said but can't respond verbally. They can only respond in short phrases. It is also called bronchoaphasia. Your receptive aphasia is a sensory speech problem, which one can't understand the spoken and often written word. Speech may be fluent, but with inappropriate content. It is also called Wernicke aphasia. And then you have mixed or global aphasia, which they have language dysfunction in both understanding and expression. Probably the most difficult is the expressive aphasia, just because they know what's being said, and sometimes they can't get the words out. We did have a lady one time that she knew what she wanted to say, and every time she tried to say something, it just came out as just like garbage, and she could hear that, and so she would get very tearful and upset. But she was able to write, so we gave her something to write with so that she could communicate with us, and that, you know, let her feel better in the fact that she had another way of communicating. Dysarthria is any disturbance in muscular control of speech. Alright, motor deficits. Alright, so you can have mild weakness to severe limitation on the contralateral side, and depending on the area of the brain involved, the stroke causes weakness, paralysis, and or spasticity. Some of your specific deficits is hemiplegia, which is paralysis of the left or right half of the body. Hemiparesis is weakness of the left or right half of the body, depending on what side the stroke happened on the brain. Remember, it's opposite sides, so contralateral. Flaccidity is the absence of muscle tone. It's also called hypotonia. Spasticity is increased muscle tone, which is hypertonia, and usually has some degree of weakness as well. Your elimination disorders. These are disorders of the bladder and bowel elimination, and these are common in stroke patients. It may also cause partial loss of sensations that trigger bladder elimination. That may result in urinary frequency, urgency, or even incontinence. So control of urination and changes in bowel habits may be altered as a result of cognitive deficits, immobility, and dehydration. Alright, when you're looking at collaboration, There are 3 treatment stages of stroke. The first is prevention of the stroke, then acute care immediately after the stroke, and then rehabilitation after the stroke, which would be more long-term. So your goals of stroke care are going to be rapid recognition and reaction to stroke warning signs, a rapid emergency medical service dispatch, rapid EMS transport, and hospital pre-notification. And so basically what happens is once the EMS picks up the patient, they evaluate them, they will call the hospital they're going to and let them know what they have and what's going on. And so that way if any resources or other supplies need to be gathered before the patient gets there, then they can go ahead and be getting that stuff taken care of so that the treatment can be started faster. You also want rapid diagnosis and treatment in the hospital setting. So diagnostic test. There is a stroke scale that helps measure level of consciousness. It is widely used to assess neurological outcome, degrees of recovery. It does look at, your CT scans will look at hemorrhaging, tumors, aneurysms, ischemia, edema, tissue necrosis. Cerebral infarct is usually visible 6 to 8 hours post-stroke. But if it is a hemorrhagic stroke, then they will see that immediately on the CT scan. So a lot of times they'll do a CT scan as soon as they think they're having a stroke, and what they're doing is making sure it's not a hemorrhagic stroke. Your stroke scales also, in addition to measuring level of consciousness, it also looks at vision, facial paralysis, their motor abilities, ataxia, sensation, language, and attention. Your cerebral arteriography is basically when they're going in and they're looking to see what the cause of the stroke is, if it's an AV malformation, if it's from an aneurysm, and so they can actually inject dye into the vessels that are in the brain, and they can actually visualize it, visualize those areas, and hopefully treat those before a stroke happens. Your transcranial Doppler ultrasound is also a test that can be done to help diagnose. Your MRIs just show a little bit more detail than your CT scan. Your PLAC blood test is used to screen for recurrent stroke risk, and that's just a blood test that can be drawn. Lumbar puncture, that is to obtain cerebral spinal fluid for examination if there's no danger in increased intracranial pressure, because that can actually cause them to have herniation of the brain. Thrombotic stroke evaluates their central cerebral spinal fluid pressure. After a hemorrhagic stroke, you'd see frank blood in the cerebral spinal fluid. Honestly, I've never seen anybody do a lumbar puncture as part of the diagnostic test for strokes, but I have seen it in several textbooks as part of the diagnostic test. Alright, so this is a couple of pictures of your cerebral angiography, and so this one over here is showing you an aneurysm that needs to be repaired, and then this one on this side is that arteriovenous malformation, and so you can see how it just ends up being this big glob of vessels. Alright, pharmacologic therapy. When you're looking at preventing strokes, a lot of times they will put them on antiplatelet agents, and that's to treat patients that have had TIAs or have had previous strokes, and that's going to be like aspirin, Plavix, Persantine, and Ticlid. Your low-dose aspirin helps reduce TIAs and stroke risk. In acute strokes, treatment is going to be ischemic stroke. They can give anticoagulant therapy, and that's going to be like Coumadin, heparin, and Lovenox. Never give anticoagulants to a patient that has a hemorrhagic stroke because you're just going to make them bleed out more. Anticoagulants don't dissolve existing clots, but they will prevent further extension of a clot, and they will prevent new clot formation. For your thrombotic strokes, they recommend fibrinolytic therapy. So TPA is an example, and it's also known as a clot buster. It is given IV within 3 hours of the onset of the symptoms of a stroke, after a CT has done to confirm that there is not a hemorrhagic stroke. Sometimes it is used in conjunction with anticoagulant therapy as well. And so these are going to be the same kind of checklist that we talked about before when we were talking about people that had heart attacks. And so you want to know the onset of symptoms, and you're basically working in that 3-hour window. If it's been longer than 3 hours, then you can't do the fibrinolytics. The same kind of things, recent surgeries, history of bleeding, all of those, they are not going to be able to use the fibrinolytic therapy. Your antithrombotic drugs are used for your at-risk patients to prevent ischemic and thrombotic strokes. And so that's going to be those antiplatelets and your aspirin. All right, surgeries. Surgeries that are done to prevent strokes, to restore blood flow after a stroke, repair vascular damage or malformations. So a carotid endarterectomy is done to remove atherosclerotic plaques. And so basically that's that rotor when they go in there and remove the plaques to kind of help open up the carotid vessels so that it decreases their chance of those plaques breaking off and causing a stroke. Alright, so when occluded or clotted vessels are not directly accessible, a extracranial intracranial bypass can be done to basically bypass the internal carotid, middle cerebral or vertebral arteries and reestablish blood flow to the brain. So basically they're just putting in another vessel and bypassing the area that has the clot or occlusion in it. Your carotid angioplasty with stenting. This is a newer option for treating cerebral stenosis. A balloon is passed through an artery in the arm or leg under fluoroscopy. The catheter is then advanced to the area of the carotid artery stenosis. The balloon is then inflated to widen that artery, and then they will place a stent in there that will permanently keep that narrowed area of the vessel open. They also, during this surgery, they will put a small filter which will catch clots and pieces of debris that may break loose while they're opening up that narrowed vessel. Rehabilitation. Physical therapy can help with preventing contractures and improving muscle strength and coordination. So a lot of these people have to learn how to walk, sit, lie down, change from one movement to another, and so physical therapy can help with this. Your occupational therapy provides assistive devices and a plan for regaining lost motor skills and to improve their quality of life. So they're going to help them learn how to eat, drink, bathe, toileting, cooking, reading, writing, and so they'll help them with that kind of thing. Your speech and language therapy will help them relearn language and communication skills. They also help with improving swallowing for eating. Looking at the nursing process under stroke prevention, you want to discuss with patients of all ages the importance of smoking cessation, avoiding drug use, maintaining normal weight through diet and exercise, which will also decrease the risk for hypertension and diabetes type 2, which are both risks for stroke. Cholesterol levels need to be screened for hyperlipidemia, so we can get them on medications to reduce that. Treating cardiovascular orders and infections like infective endocarditis is going to be important. All right, increasing awareness of warning signs of TIA or stroke, and to call 911 so that they can get to the hospital and start treatment quickly. So things you're going to teach are going to be sudden weakness or numbness of the face, arm, or leg, especially on one side of the body, confusion, difficulty speaking or understanding speech, sudden trouble walking, dizziness or lack of coordination, increase the awareness of warning signs, like sudden difficulty with vision in one or both eyes, sudden severe headache without cause. They've done a really good job of putting out information on warning signs of stroke because they're so common, and so most of the lay people now know how to assess for symptoms of a stroke. All right, so the National Stroke Association Act, they came up with this acronym called FAST. So the F is face, and so looking at is there any facial drooping. A is arm, so looking at arm weakness. S is speech, looking for slurred speech. And then T is time, calling 911 if any of the previous are present. All right, and looking at assessment, for health history, you want to assess for risk factors. Have they had a previous stroke? Any drug use, whether it be prescription, over-the-counter, or street drugs. Asking about their smoking history. If they do come in with symptoms of a stroke, you want to know when the symptoms began, their severity, have they had any incontinence, their level of consciousness, do they have a good family support system. For physical assessment, you want to evaluate their level of consciousness and communication, assessing motor strength, coordination, assessing cranial nerves, as well as sensory function. These are your NANDA diagnoses for strokes. In planning, goals may include that the client will maintain blood pressure within normal range, understand importance of cardiac rehabilitation, ambulate and increase activity as tolerated, and participate in therapies that maximize communication techniques. In implementation and maintaining cerebral perfusion, you want to monitor respiratory status and airway patency. The patient is often unconscious and breathing is impaired. They may have respiratory complications that happen very fast. You may hear crackles or wheezing upon auscultation. May have rapid respirations or even respiratory acidosis. Suction them as necessary, but avoid prolonged suctioning because that can lead to increased intracranial pressure. Side lying position, that helps with aspiration. Oxygen is ordered to reduce the risk of hypoxia and hypercapnia that can increase cerebral ischemia as well as increase intracranial pressure. You want to assess mental status and level of consciousness. They may have restlessness, drowsiness, lethargy, inability to follow commands, or they may be unresponsive. They may have increased intracranial pressure, which is the major cause of death in an acute phase of the stroke. So if you have any of those above symptoms, then you want to make sure you're monitoring increased intracranial pressure. All right, so other things to monitor for cerebral perfusion are going to be strength and reflexes. You're also assessing pain, headache, decreased muscle strength, sluggish pupils, absent gag or swallow reflexes, hemiplegia, Babinski sign. So sometimes you may see a Babinski sign in an adult, which is not a good thing. They have decerebral or decorticate posturing, All of these will indicate increased intracranial pressure. You want to monitor their cardiac status, monitor them for dysrhythmia, so keeping them on a heart monitor. Monitor their temperature for hyperthermia, which may develop if the hypothalamus in the brain is affected. Monitoring intake and output. Measuring output with a Foley is going to be important. If the pituitary gland was damaged with a stroke, then diabetes insipidus can develop, which causes them to have copious amounts of output. It can be several liters a day, and this will cause dehydration. You also want to monitor for seizure activity, so making sure that you pad the side rails. You want to give the prescribed anticonvulsants, because anytime you have something going on in the brain, that will increase their risk of developing seizures. So sometimes they go ahead and put them on prophylactic anticonvulsants. Promoting physical mobility. You want to encourage active range of motion for the non-affected side at least every 4 hours, and passive range of motion for the affected side. And so the nurse and the physical therapy can help with those passive range of motions. You want to turn and reposition them every 2 hours to help maintain body alignment and support extremities with pillows, elevating the head of the bed 30 degrees. That helps with aspiration risk. It also helps facilitate breathing. You want to assess lower extremities for thromboembolism formation. So you're looking for increased warmth and redness, measuring the calf and thigh circumference daily. You want to consult with physical therapy as patient gains mobility. You want to use consistent techniques to move the patient from the bed to the wheelchair and to help them ambulate. Because if everybody's doing it the same way, then that's going to reinforce those movements in a certain way. Promoting self-care. You want to encourage them to use the unaffected limb for self-care, such as bathing, brushing their teeth, combing their hair, dressing themselves, and eating. I also want to teach them to dress the affected side first so that they can dress themselves with minimal assistance. Consult with occupational therapists to schedule times to train them for ADLs, encouraging them to use assistive devices for eating, physical hygiene, and dressing. Promoting verbal communication. You want to approach and treat the client as an adult, and don't assume that the client has a hearing deficit if they don't respond, so don't scream at them and raise your voice. You want to allow them an appropriate amount of time for them to respond. It may take them a little bit longer to respond than normally. Making sure that you face the client and speak slowly. If they are unable to understand the patient's speech, be honest and say that you can't understand them. Don't just pretend you do. You want to use short, simple statements and questions. Accept frustration and anger as normal reaction to loss of function. Try alternative methods of communication, such as writing tablets, flashcards. There are some computerized talking boards that can be of assistance. Promoting urinary and bowel elimination. You want to assess for urinary frequency, urgency, incontinence, and nocturia. You want to encourage bladder training, and so that would be having the patient void on schedule, like every 2 hours. You can also teach Kegel exercises, and that will strengthen the pelvic floor to help decrease incontinence. You want to use positive reinforcement, so verbal praise for successful management of their urinary elimination. You also want to discuss pre-stroke bowel habits and their bowel habits since they've had the stroke. So you can compare those to see if there's anything that has changed, and so we may need to change treatment. Alright, so you want to encourage fluids up to 2,000 milliliters a day if it's not contraindicated. high fiber diet. And so if they are not having any swallowing difficulties, then you're going to do the fluids and the high fiber diet. If they're having swallowing difficulties, then they may need nutrition with another source, whether that be TPN or some enteral feedings. You want to increase physical activity as tolerated. You need to assist with using toilet facilities at the same time every day to help establish a routine. Administer the prescribed stool softeners. Maintaining safety. Dysphagia, which is difficulty swallowing, can cause choking, drooling, aspiration, and regurgitation. You want to monitor swallowing studies before giving oral foods and fluids, making sure that they've passed those swallow studies. And a lot of times what speech therapy will do is they call it a blue dye test. And so they may put blue dye in applesauce or on some like Lorna Doone cookies, and they'll have them eat those and swallow them and then try to suction them to see if they are aspirating into their lungs. So they always use blue dye because there's really nothing in the body that should be blue. Never use red because it could look like blood. Alright, ensure safety when eating, so they need to be in an upright position with the neck slightly flexed. They need pureed or soft foods. The liquids should be the consistency of honey, so there's a powder that will actually thicken your liquids. Alright, other things to ensure safety while eating is eating and swallowing techniques, so putting the food behind the teeth on the unaffected side, making sure they tilt their head back to swallow, and this kind of helps them to make sure that things don't stay in their mouth and hopefully they go down the right track. You want to assess for coughing with eating and drinking. They could be aspirating, so making sure you have suction equipment set up at the bedside. If they do start choking or aspirating, you want to monitor lung sounds to make sure that they're not getting fluid and stuff in their lungs. Help minimize distractions because it's going to take them a lot more effort to eat than normally, so it's going to expend a lot more energy. Evaluation. Some of your expected outcomes may include client participates in rehabilitation. They will communicate their needs effectively. They will receive adequate family and community support, and they will experience minimal complications from immobility, dysphagia, and reduced motor or sensory functions. And so this is the end of the lecture on strokes or CVAs. And as always, if you have questions, let me know and I'll try to help clarify.